So for diagnostic purposes, I wonder if you could comment on bone marrow versus blood workup. What's essential to have to make a diagnosis of CLL?
I think in most instances we get by with doing a peripheral blood analysis, and as long as the patient has greater than 5 × 10⁹ per liter monoclonal B cells with an immunophenotype characteristic of CLL, that in my opinion is sufficient to make a diagnosis. In a patient with cytopenias, it might be important to do a marrow to ascertain the basis of the cytopenias. Is it due to extensive marrow involvement? Is there pure red cell aplasia? And other considerations might be contributing to the cytopenias. So certainly I think bone marrow is useful in many cases. I'm not sure it's required in absolutely all cases. Depends on the CBC.
In terms of the prognostic significance of these markers, maybe we'll start with you, Nitin. And can you comment on the prognostic features for this patient and how that might be related to the outcomes for this patient?
For this particular patient, given that the patient has deletion 11q, in studies with CLL, that is shown to be a high-risk prognostic marker for patients with CLL with lower progression-free survival and overall survival in the context of chemoimmunotherapy. And also, patient has unmutated V gene, which again has been associated with higher risk prognosis with decreased progression-free survival and overall survival compared to the mutated V gene. So certainly both these two prognostic markers, which tend to go hand in hand most of the time, deletion 11q and unmutated V gene, I think this patient certainly is at high risk of disease progression. She's already showing signs of disease progression with anemia. And I think she is kind of, I think we should consider treatment for this patient.
So based on that, what you just indicated, we should be talking to this patient about treatment. And this is an older patient in their 70s. We have really two different approaches to treatment for this patient. We can approach treatment in terms of chemoimmunotherapy, and then we have the new small molecule inhibitors that we need to discuss about treatment options for this patient. So maybe we could start out with the chemoimmunotherapy, since we have a lot of long-term data for chemoimmunotherapy, and maybe you can summarize for us the studies that have been done that are relevant for the older population with regard to chemoimmunotherapy and the treatment options and the outcomes associated with those options.
Sure. So the studies I wanted to highlight. So one is the CLL-10 trial, which is actually a trial for the younger patients for CLL, which were treatment-naive fit patients, less than generally 65 years of age, though the patients above 65 years of age were also treated in the study. And in that particular trial, patients were randomized to receive either FCR, fludarabine cyclophosphamide rituximab, versus bendamustine rituximab. And this was done by the German CLL study group with a primary endpoint of progression-free survival. And what the study showed was that for older patients, which were approximately 1/3 of this group of patients, when they compared FCR versus BR among the above 65 years of age group, they had similar progression-free survival. However, when they looked at the study overall, FCR arm had a superior progression-free survival. Above 65 years of age, FCR regimen did lead to increased cytopenias, neutropenia, and infection risk. So I think that study may tell us that if you have an older patient where you're thinking about chemoimmunotherapy, bendamustine rituximab may be a reasonable alternative to FCR. However, there is another trial led by the German CLL study group, CLL-11 study, which was really designed for patients who were older or who have comorbidities, where patients were randomized to receive either chlorambucil as a monotherapy versus chlorambucil plus obinutuzumab versus chlorambucil plus rituximab. And what that study shows that the arm with the chlorambucil rituximab, or chlorambucil plus obinutuzumab, was the most superior in terms of progression-free survival as well as the overall survival compared to the other arms. And this particular study led to the approval of this regimen, chlorambucil plus obinutuzumab, as the standard of care for patients, for frontline therapy for older patients with CLL. So that's another option we have available in terms of the chemoimmunotherapy, whether to go with the chlorambucil plus obinutuzumab versus maybe a bendamustine rituximab approach.
So your choice of chemoimmunotherapy regimens, you reviewed a couple of chemoimmunotherapy regimen options for the patient. The choice between the options is driven more by?
So I think it's driven more by the overall performance status of the patient, comorbidities. Bendamustine rituximab is likely going to be a more myelosuppressive regimen than chlorambucil plus obinutuzumab. So I think if you have a patient who is maybe 65 to 70 years of age, have a good performance status, good organ function, and you are thinking about chemoimmunotherapy, then I think BR, bendamustine rituximab, may be a reasonable alternative. However, a patient such as this patient in 75 years of age, I think if you are looking for chemotherapy, then maybe G-chlorambucil or obinutuzumab chlorambucil might be a better option.
And the expected progression-free survival with chlorambucil obinutuzumab in this patient population would be?
So in the CLL11 trial, the median progression-free survival for this patient population was 31 months, so just over 2.5 years or so.
And in terms of relapse with this type of treatment, with the patient characteristics that this particular patient has, maybe you can comment on what the long-term outcome, the expectation for long-term outcome for this patient.
Yeah, so this patient has deletion 11q as well as unmutated V gene. Both of these have been shown to be high-risk prognostic markers with chemoimmunotherapy. So certainly what I mentioned, 31 months, would be applicable to all patient population when you include everyone together. Given that this patient is high risk, I would expect that the median progression-free survival would be certainly less than that, probably in the order of 1 to 2 years. So certainly I think that remains suboptimal with the chemoimmunotherapy, but that's what you could potentially achieve with chlorambucil obinutuzumab.
So we would be talking to this patient likely in a relatively short period of time about retreatment, relapse and retreatment.